All right. So actually, as Dr. Park mentioned earlier, I'll be speaking on the role of palliative care in colorectal cancer. I'm very delighted that palliative care is being highlighted in an oncology platform. So I'll be speaking on mapping the availability of palliative care services to address the gaps in LMICs and beyond. Um, I'll begin with the introduction to palliative care, which most of you already know, and I'll continue to speak on the palliative care needs among colorectal cancer patients, and followed by the findings of the palliative care mapping study, which was done in Malaysia, and we'll end with the conclusion of the study. So basically, palliative care is care which is provided to patients who are facing any life-threatening or life-limiting illnesses. And it's not just limited to the patients alone, but it also extends to the caregivers, or their family members. And it can be, what's unique about palliative care is it can be offered in various settings, not only in the hospital setting, but it can also be given as outpatient services, health centers, and nursing homes, and even in the home setting. So it aims to improve the quality of life, and it indirectly helps or benefits the health system by reducing unnecessary hospitalizations and ICU admissions. So it aims not just to cover the physical symptoms alone, but also psychosocial and spiritual suffering. Yeah. And the uniqueness of palliative care is it can be provided not only by doctors, but also by volunteers and all layers of the health workers. And it's a very flexible service whereby a patient transition from one level to another level is often, it happens often, depending on the complexity of their need. And if you can see in this image shown here, the largest need of the population remains at the community level, and those who are at the closest proximity to the community, or better known as gatekeepers, are the primary care doctors. Yeah. So, as I mentioned earlier, it ensures value. It improves quality of life and reduces symptom burden. So, generally, it reduces distress in a patient with palliative care needs, and they see a 66% of improvement, especially when palliative care is introduced earlier during the disease trajectory. And a very vast majority of patients who receive palliative care are very likely to recommend it to others, because it has a lot of positive impacts, not only on the patients, but also their caregivers. However, it is known through the available literatures that patients in LMICs rarely have access to pain relief and palliative care services. Although 83% of the population are from the LMIC, however, only 9% of the global opioid consumptions are by the LMIC population. So the absence of palliative care, especially in low resource settings, results in significant cost being absorbed in an out-of-pocket mechanism, either by the patient or the family. And this causes financial catastrophes, a big hole in the pockets of those dealing with all the serious health-related suffering. And it has a long-term effect, especially in stunting economic growth. So every year, about 25.5 million people die with serious health-related suffering, and they have palliative care needs, and that's nearly half of the deaths. And 80%, over 80% of these 25.5 million are from the low and middle income countries, where access to palliative care is severely lacking. And this is highlighted in the study done by the Lancet Commission of Global Access to Palliative Care and Pain Relief. So now let's look a little bit into the colorectal cancer. Despite advances in screening, diagnostic tools, and other options of treatment, it still remains as the third most common cause of cancer overall, and it has a high mortality rate. And these are things that we know that researchers have noticed. There's an increased evidence showing there's incidence of colorectal cancer among the younger population, those who are below 50, increasing in trend. And there's a pattern of delay in seeking medical attention due to limited screening, especially in areas with limited resources and diagnostic tools, and there's also a delay in recognizing other needs, which we will look into later. So we can see that early onset of colorectal cancers are increasing, and this brings in a lot of challenge to the health system in various regions across the globe, especially challenges like premature death. And although we have survivors, they actually survive with many side effects, and it impacts their quality of life. And the screening, however, most of them are sticking to the general guidelines, and aggressive treatment actually sometimes gives a lot of other side effects, as I mentioned earlier. And the risk factors are not definite as how we used to know it traditionally is. Yeah. And we're still following the same guideline to treat the younger patients. In most regions, they still follow the same guidelines to treat the younger patients. So, early introduction of palliative care actually improves the quality of life throughout the disease trajectory, because the palliative care needs evolve uh, from one stage to another, different kind of needs based on the disease trajectory, which is why it's very important that palliative care is introduced earlier on so that it can be tailor-made to suit the patient and caregiver needs. So we all know that the three words that nobody wants to hear is that you have cancer. All right, because it doesn't just bring about physical symptoms, it also affects. Speaking of physical symptoms, they'll be dealing with issues which can be helped through palliative care, such as pain, fatigue due to weakness from treatment, neuropathy, changes in bowel habits, and so on. As for psychosocial and spiritual needs, they can be dealing with anxiety, depression, insomnia, grief, and other spiritual dilemmas, which palliative care has evidently shown a good outcome when offered to patients with these complications. And they also have other needs such as financial strains, logistic issues, and decision making, which is why treating pain, symptoms, and the stress of the cancer and its aftermath is as important as treating the cancer. So it's not just about treating the cancer, but all these other symptoms which comes along. So let us look at the palliative care needs among patients with colorectal cancer. There will be physical symptoms such as I mentioned earlier, pain, dyspnea, fatigue, weakness, nausea, vomiting due to the treatment, side effects, diarrhea, constipation, dry mouth. I'm sure you all can see. And other psychological effects which may not always be looked into in the oncology settings, in especially in low resource settings. Yeah. And other issues such as social and spiritual needs, whereby palliative care comes in and looks at the patient in a holistic manner and aims to improve their quality of life. So how is the setting, palliative care in the LMIC setting? Looking at the primary and community palliative care in LMIC, it's primary care is regarded as the most inclusive, equitable, and cost-effective way to achieve UHC. And currently, it's being urged to incorporate palliative care and symptom management into the primary care system. So the health systems are being urged. However, in reality, it's not what's happening in LMICs. So most of the primary palliative care literatures actually centers around the systems in the high income countries. So we don't really know what's going on in the LMICs. So this was shared by Dr. Rajagopal in one of the conference from Pallium, India. Are we looking at the palliative care needs from the high income countries lens? And do we know what exactly people in LMIC suffer from? Because despite being more than 85% LMIC population, despite it being more than 85% of the global population, only 6.5% of the palliative care literatures are coming from the LMICs. So this shows that it's a very increased need to show what is going on, the real things that's going on in LMICs has a far way to come. And it's a basic human right to include pain management and palliative care, but it's currently, as I mentioned earlier, it's not being integrated into national health systems, and this results to millions of people in LMICs having limited access. Because as we saw earlier, it improves quality of life, reduces hospital admissions, and reduces access to emergency rooms, and it improves the opportunity to discuss sensitive issues. Yeah, the palliative care actually trains the healthcare workers to speak and explore more into the sensitive issues, and it gives improved symptom control and also psychological support. So this brought us to look into the availability and accessibility to palliative care in Malaysia, which is a upper middle income nation. And this study is actually a part of the mixed method study. And we mapped the palliative care services across various levels. And we explored the types of services, distance, and cost to travel to the nearest facility offering palliative care in every state and district. So data collection was done by mapping the distance to nearest facility from the center of each district. And we looked into the cost and travel time via car and public transport. We use the Google Maps and the Roam to Rio app to estimate these two components. So all districts in Malaysia were samples. And let me show you, this is the map of Malaysia, and how the distribution of palliative care service. We mapped all different types of services, which is hospital-based services, community, domiciliary, palliative care, and so on. So what I'm actually showing here, this area which shows Selangor, Kuala Lumpur, and Putrajaya, this is the central region, which is more highly developed, a lesser poverty rate, and higher gross median household income. Okay, it has a higher distribution of various types of palliative care services, whereas within Peninsular Malaysia itself, the East Coast, which comprises these three states, Pahang, Terengganu, and Kelantan, you see that the distribution of these services are quite scarce, especially community palliative care services. And it's even worse when it comes to Borneo, or we call it East Malaysia, where the state of Sabah and Sarawak is. It's a lesser developed part of Malaysia, and the poverty rate is higher here in Sabah and Sarawak, as well as Labuan. The gross median monthly household income is also lower in these regions, and geographical disparities is an issue in this region, which is East Malaysia. So you can see the services are not equally distributed. So we also looked at the types of services which were offered in various layers of the healthcare system, namely the hospital-based care, domiciliary palliative care, which means services offered by the public health clinics in Malaysia. So the nurses actually go to patients' houses and offer some form of palliative care. And we also compared it with community-based palliative care, which is provided by the NGOs mainly. You can see we try to map the type of services available across settings. And you can see, again, it is not equally distributed, meaning if you're receiving palliative care at the hospital level, you somewhat get a better quality or higher quality palliative care services, because it is not standardized how one service functions and compared to the other. So the service, the type of services is not equally distributed. And you can see this is showing the district distance from each state based on the average distance. Yeah. So what the first box here shows the central region. Yeah. The average distance that they need to travel from each state is less than 10 kilometers, and the furthest distance that they have to travel in the central region is less than 20 kilometers. However, if you go to the state of Pahang, the east coast of Pahang, which is in Peninsular Malaysia, the average distance people of Pahang need to travel is about 158 kilometers, and the furthest distance is 363 kilometers. So we can do a simple maths to know how many times fold is that. And now I will move on to the third box here, which shows how is the distance for people in the East Malaysia, which is Borneo, Sabah and Sarawak. And similarly, it's more than 100 generally, and the furthest distance is more than 150 kilometers, and the furthest will be in Sarawak, where people need to travel about 309 kilometers to the nearest facilities offering basic palliative care service. So it shows that the further they stay and the poorer they are, it is more difficult to obtain and access palliative care services here in Malaysia. So this is a summary of the study where we can conclude that specialist palliative care, or about 48%, almost 50% of the services are concentrated in the more developed central region. Okay, and some are not led by people who have palliative care training. So they are led by other department specialists who've had some short attachment in the palliative care units. So we are not able to look at the quality of services here. As for domiciliary palliative care services, which is offered by the public health clinics, as of 2021, it was only available in 50 clinics, and it was a pilot project was done, and only 4 states out of the 14 states in Malaysia had these services. And then once again, we can see that the majority of these facilities are again in the central region. However, the care provided by this team was very basic. What they were offering was mainly simple procedures like the changing of rice tubes, CBD, dressing, and things like that. And it did not encompass the holistic palliative care services that has to be provided. Okay, and as for the NGO community palliative care, we have about 28 NGOs across Malaysia and one by the National Cancer Institute. However, once again, it's concentrated, about 23% it is in the central region. And even though it's available in other states, it's mainly in urban areas. So people living in the urban areas do not have good access to palliative care. And we do not have minimum standards across the nation, so services vary from one service to another. However, in terms of accessibility, I will move to the accessibility. Generally, Malaysians travel about 40 kilometers to access to the nearest facility offering palliative care services. However, there is a vast disparity between the people of Central Region and people of East Coast and East Malaysia. Those in Central Region, the median distance is only about 3.7 kilometers, whereas those in the East Coast, they travel about 45.7 kilometers, and East Malaysians travel 82.3 kilometers. As for the median cost to travel via public transport, generally Malaysians spend about 5.8 USD one way in the public transport, and people in the central region spend way lesser, which is less than $1. However, those in the east coast of Malaysia spend USD 7.2, and those in East Malaysia spend fourfold, which is about 21 US dollars. And as for median time taken to travel via car, generally Malaysians travel about an hour. Those in central region, they travel less than 20 minutes. And again, once again, those in East Coast travel around 70 to 80 minutes, and those in East Malaysia, they travel about 110 minutes one way to access to the nearest facility offering palliative care. And if they use public transport, it's even further. And I would like to highlight here that there's a district in Borneo, in the state of Sarawak, named district of Daro and Matu. Yeah, people need to travel, the population of this district, they need to travel about 2.5 hours via a boat ambulance due to geographical disparities to access to the nearest facility offering palliative care services, where most of the people with palliative care needs in areas like this, they prefer to just stay at home and suffer and have a painful death. So, summary of the key findings which I've identified in the mapping study among Malaysia, which I feel could be similar in many other middle income and lower middle income nations, is there is a stark disparity in access to palliative care services, and the range of services that are offered from one layer of to the other layer of the healthcare system, and from one facility to another facility, is not widely standardized. and this may cause potential financial burden to care and also caregiver exhaustion, and also logistic issues to the population who are in need of palliative care services, and they lack healthcare workers lack in universal training. So currently, the healthcare workers are just doing the best from what they can offer. Okay, and there's also unequal access to opioids at different layers of the health service, as we mentioned earlier. Generally, people in LMIC are all facing these issues as well. So, in conclusion, I think it's important to ensure that effective palliative care service is provided within primary care. It is not just a medically imperative need, but also a moral one. It serves as a beacon of hope for patients and caregivers and their yearnings for sustained and compassionate care. So health systems in the low and middle income countries actually have a unique strength that needs decentralizing these services from a hospital-based services to a more accessible services, and primary care facilities are in the greatest position to offer them. And it can actually do a great help to meet the future needs of palliative care among populations in LMICs. So these are my references, and I would like to end my session by saying that universal health coverage is not universal without palliative care, especially to those with serious health-related suffering and people with cancer. And everywhere, regardless whether it's a high or middle or low income country, palliative care must be as available as air. With that, I thank you all.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.